Dr. Madhu Chaudhry, and I will be your Division of Faculty for Pathology. Okay, today's topic is problem solving exercises in anemia. See, anemia as such is very important for a doctor, be it in your MBBS life or following that also. Anemias we've studied everywhere. Anemias we start with physiology, we start study in pathology, we study in medicine. But anemia as such is a very important topic for a doctor. I just now told you we study this in all these subjects. Plus, later in your life, when you all become very successful doctors, you will definitely get anemia. Either you are an intern, you are a JR, you take up post graduation, you become successful doctors, any branch, anemia will always be important. Okay, so let's start with the problem solving exercise. We will go case by case. We will discuss three cases in this session. Any doubts, any discussions, please do write it in the chat box. I'll try to answer all your queries. Let's start with the case one. Okay, we have a 32-year-old female who comes with a complaint of fatigue, dizziness, shortness of breath on exertion for the last 3 months. She reports heavy menstrual bleeding for the past 6 months but denies any other blood loss. Please note, history is very, very important in diagnosing a case of anemia. So, what is a direct history, direct finding that we can find it in this case? It is heavy menstrual bleeding. Okay. On examination, we found out she has pallor, she has mild angular cheilitis, koilonychia, and no hepatosplenomegaly. I hope all of you know what is koilonychia. It is spoon-shaped nail. Okay, very characteristically found in anemia. Koilonychia means spoon-shaped nails, right? Further, we investigated the patient. The hemoglobin was around 8.1, MCV was 68, MCH 22, RDW 16.5, total RBC count was reduced. Okay, before I move ahead with the further investigations, I would like to point out this sort of a case you can get in your theory exam as well as in your OSCEs and practical. This could be a simple MCQ also asked in your competitive exams. So these days, clinically integration is very important, be it in your theory, be it in your practicals, or be it in your MCQ perspective, right? So, and whenever you get such a case, I would request you to list down all the lab parameters they have given it to you. I'll just now do it in a while when we study about the lab parameters. Okay, very important. You just need to list down all the parameters. Okay, so we've studied about the CBC. HB is 8.1, MCV is 68 femtoliter, MCH 22 picogram, RDW 16.5%, total RBC count reduced. Please note, students, you have to learn the normal values of all these indices and you must be knowing the units also. Right. Now, coming to the iron studies. Serum iron, we've seen it is 25 microgram per deciliter, total iron binding capacity, TIBC, 450, ferritin 10 nanogram per ml. And this is the peripheral smear finding that they have given to you. Now, they have asked us questions. What is the most likely diagnosis based on the given history and lab findings? First. Second is, how can you differentiate between anemias of this category? How can investigations help understanding the pathogenesis of the diseases? So, we studied the case history. We studied a 32-year-old female who has come with shortness of breath, dyspnea on exertion, heavy menstrual bleeding. Most important, she has pallor, she has cheilitis, and she has koilonychia. We have all the CBC parameters, iron parameters, and we also have the peripheral smear findings. Now, let's try to answer each and every question. First question, What is the most likely diagnosis based on the given history and lab findings? History, most important finding in history, it is heavy menstrual loss. That is chronic blood loss. There is chronic blood loss. Okay. Now, physical examination. What have you found in physical examination? Most important physical examination finding is your pallor. That means the patient is anemic, but we have to find out which type of anemia. The patient has pallor, patient has koilonychia. Okay, most important. And there is no hepatosplenomegaly, right? No hepatosplenomegaly. Please note no hepatosplenomegaly. This is going to be a very important differentiating feature. Now, coming to what are the lab findings? Lab findings, I just now told you, whenever you get all the parameters, please try to list down all the parameters. Now, what are the parameters they've given it to us? Hemoglobin is 13 gram per deciliter. What is the MCV that is given? MCV is 68 femtoliter. MCH is 22 picograms. Okay, these are the parameters that they've given it in CBC. Now, can anybody tell me what is the normal hemoglobin for a 32-year-old female? Normal hemoglobin for a 32-year-old female would be around, yes, it will be around, sorry, our patient has 8. Our patient has 8 hemoglobin, and the normal hemoglobin in this patient would be around 10 gram per deciliter. What's the normal MCV? What is MCV? Mean corpuscular volume. What does it indicate? MCV indicates, yes, MCV reflects the size of the RBC. And what's the normal RBC, normal MCV that we have? 80 to 90 femtoliter. Please note that MCV less than 70 is microcytic, more than 90 is, this we term the cells as macrocytic. What's the normal MCH? Normal MCH is around 22 to 27 to 30 picogram. Okay, 27 to 30 picogram is the normal MCH. So we know hemoglobin is reduced, MCV is reduced, MCH is reduced. We have another RBC index. I hope all of you know. Another RBC index that we know is your MCHC. What is MCHC? Mean corpuscular hemoglobin concentration. And what's the normal value? It's around 30 to 35 gram per deciliter. This is very basic. I hope all of you know and all of you have to remember these values. Even if you're not sure of the exact range, you should be knowing that 68 femtoliter is at a lower level. 105 femtoliter is at a higher level. So you should be having an average idea of the reference range, even if you don't know the exact value, right? So this was the RBC value indices. Now they have also given us the RDW. They have given RDW as 16.5%. What is RDW? RDW is red cell distribution width. And what does it reflect? It reflects the variation in the size of the RBC. Normal RDW is around 11 to 14%. So this value is increased, right? I just now told you MCV reflects the size of the RBC. If they ask you which parameter reflects the size, it is MCV. Which parameter reflects the variation in the size? It's your RDW. Please note, very important question, very important Viva question, very important question from your NEET perspective also. MCV reflects the size, RDW reflects the variation in size. Okay, now what other parameters they have given it to us? They have also given the iron studies. Iron study, they have given us Serum iron, that is around 25 microgram per deciliter. TIBC, what is TIBC? Total iron binding capacity of a cell, of an RBC. How much? See, you can always correlate the TIBC to the hunger of an RBC. If you go to a restaurant and you go to a restaurant where buffet is being served, right? You see food everywhere. That is, you are an RBC and the food is iron, right? You see food everywhere, everywhere, everywhere. What will happen? Your hunger capacity will be low. And once you are starving or you are fasting, you don't have to eat food. That means your hunger will be more. Your craving for food will be more. So you can always correlate TIBC with the hunger of the RBC. So here, since iron is low, your TIBC should be more because there is no food here. So TIBC, they have given the value as 4, sorry, TIBC, they have given the value as 450 microgram per deciliter. Okay, and they have also given us serum ferritin, which is 10 nanogram per ml. Now, what are the normal values here? Serum iron normal value is around 50 to 150 microgram per deciliter. TIBC is around 250 to 450 microgram per deciliter. Ferritin is 30 to 250 nanogram per deciliter. So if we see here, is our iron is reduced, TIBC is increased, and ferritin is reduced. So these are the lab findings. Your hemoglobin reduced, it's anemia. MCV reduced, the cells are microcytic. MCH reduced, it is hypochromic. RDW, variation in the size, that is increased. That is, there is increased production of cells from the bone marrow. That is why the cells are being early released into the blood, and that is why there is variation. Now, coming to the iron studies, your iron is low, your hunger capacity is increased, your ferritin is low. So, it is a case of, yes, definitely it is a case of your iron deficiency anemia. Okay, it's a case of iron deficiency anemia. Iron low, ferritin is low. What is ferritin? Ferritin is the stored form of iron. Okay, please note in iron deficiency anemia, which is the first indicator to get reduced. The first indicator to get reduced would be your ferritin. I hope all of you remember the stages of iron deficiency anemia. When there is deficiency of iron, which iron is going to be utilized first? The stored form, that is the ferritin form, which is going to be utilized first. So your ferritin would be the first parameter which is going to decrease. This is also very important. Please note these important things. They can ask you in Viva, they can ask you in as an MCQ also. Which is the first parameter to get reduced in iron deficiency anemia? It is your ferritin. There is one more parameter which is not given in this case, but we should be knowing about is your transferrin saturation. Now, what is transferrin? Transferrin is basically an iron transport protein. Now, iron is deficient, so your transferrin saturation would be reduced. Transferrin saturation is reduced, then your transferrin receptors would be more. Your transferrin receptors would be more. We have one parameter which can differentiate iron deficiency anemia from anemia of chronic disease. See, iron deficiency anemia is a microcytic hypochromic anemia. We have another microcytic hypochromic anemia, which I am going to discuss it in a while. is anemia of chronic disease. There also you see microcytic hypochromic, but it is not due to iron deficiency. So a differentiating parameter is your serum transferrin receptor divided by log of ferritin. In iron deficiency anemia, this parameter is more than 1.5, and in anemia of chronic disease, it is less than 1.5. Very simple to understand. Why? Because in iron deficiency anemia, your ferritin is going to be reduced, transferrin receptor is going to be increased, so your ratio would be more than 1.5. And anemia of chronic disease, it will be completely ulta, right? So the ratio would be less than 1.5. So till now, we made the diagnosis as iron deficiency anemia. But one thing we have left out is the peripheral smear. The peripheral smear that they have given us. Even if they wouldn't have given us a peripheral smear, we could have made the diagnosis as iron deficiency anemia. Clear? But this peripheral smear also helps us. What do you find in the peripheral smear of a microcytic hypochromic? Sorry, what do you find in the peripheral smear of a iron deficiency anemia? Yes, you will find microcytic hypochromic cells. That is very simple. Microcytic hypochromic. How do you define cell as a microcytic? What's the normal diameter of an RBC? Normal diameter is, it's around 7 to 6 to 8 micron. Okay, that is the normal diameter. If it is less than 6, we label the term as cell as microcytic. If it is more than 9, we label the cell as macrocytic. And how will you determine? See, you will not see a scale and determine the size of the cell in a peripheral smear. How will you determine the size of a cell RBC in a peripheral smear? By comparing it with a normal small lymphocyte. Okay, the normal small lymphocyte size is almost comparable to the size of a RBC. So here we see very small cells. These are your microcytic cells, right? And we also see hypochromic cell. Now, how do you label the cell as hypochromic? See, in an RBC, what's the shape of an RBC? It's biconcave or discoid shape. It is like this, biconcave or discoid shape. When you stain the cell, very good, somebody has already given the answer, less than 1/3 of the red color. Now, how do you find 1/3? Okay, when you stain the cell is usually taken up by the periphery. So this cell is this portion of the cell takes up the stain. On the slide, you see the cell like this, right? So this is pale. This is called as central pallor. Now, is the central pallor normal? Yes, it is normal till the time it is 1/3. This central pallor is normal till the time it is 1/3 the diameter of RBC. The moment it becomes more than half the diameter of RBC, you call it as a hypochromic cell, right? So this is your microcytic hypochromic blood picture. If you see these cells, this is the pallor. This is so much. It is more than half the diameter, right? With these cells, there is a lot of pallor. Very good. Pencil cells are also seen. Yes, very good. These are your pencil cells. One more finding. Can anybody tell me? Pencil cells, very good. One more finding which you can see here. Anybody? You see microcytic hypochromic, you see pencil cells, there is variation in size, there is anisocytosis, there is some variation in shape. What is the term that is called for variation in shape? Can anybody? Very good. It is poikilocytosis. Yes, you also see teardrop cell. Which is the teardrop cell? Yeah, you can see some of the teardrop cell. Very important poikilocytosis. Also, I told you poikilocytosis is variation in the shape. So you've seen microcytic cell, you've seen hypochromic cell, you've seen pencil cell, you've seen teardrop cells, anisocytosis, poikilocytosis. Very important. You see leptocytes. What is the other name for leptocytes? Leptocytes or pessary cells. Leptocytes or pessary cell is something like this. The pallor is so much that you see just a ring of cell. That is your pessary, right? You just see a small ring cell. That is a pessary. See, if you see the pallor is so much that you just see an outer ring. That is called leptocyte or pessary cell. So we are very clear. This is a case of iron deficiency anemia. Your hemoglobin is less, MCV reduced, MCH reduced, iron reduced, CIBC raised, and ferritin reduced. On the top, they've given you the peripheral smear. It is a classical case of microcytic hypochromic blood picture. Now, can we move on to the next question? Okay, how can you differentiate between anemias of this category? We all know this traditional mnemonic, that is Sita. I hope all of you know. Just give me a thumbs up if all of you know this full form of Sita. Yes, very good, Rakesh. Full form of Sita is your sideroblastic anemia. Very good. I am so happy to see that all of you know sideroblastic anemia, iron deficiency anemia, thalassemia, and anemia of chronic disease. So these are your four classical microcytic hypochromic anemias, right? Now, how will you differentiate them? We all know sideroblastic anemia. What is the pathogenesis for sideroblastic anemia? Here, there is no iron deficiency, but because of a deficient enzyme. Can anybody tell me which enzyme is deficient in sideroblastic anemia? Very quickly. I am just waiting for the chat. Can anybody tell me which is the enzyme deficient in sideroblastic anemia? No, it is not it is ALA synthetase. Okay, ALA synthetase is deficient, which results in deficient hemoglobin synthesis. Here, yes, very good, Samiksha. It is ALA synthetase that is deficient, and because of that, even though iron is present in the diet, there is no deficiency of iron, but hemoglobin cannot be formed. Iron deficiency, we have already studied, it is deficiency of iron. Thalassemia, it is due to the hemoglobin defect, right? It is either alpha thalassemia or beta thalassemia. Now coming to anemia of chronic disease. It's ALA synthetase, right? Anemia of chronic disease. Now can anybody tell me in anemia of chronic disease, what is exactly what is increased? Or just let me ask you a question differently. Which is the master regulator of iron homeostasis? Which molecule is the master regulator of iron homeostasis? Hepcidin, very good. Hepcidin is the hepcidin is the master regulator of iron homeostasis. Because of inflammation, because of a chronic disease, your hepcidin, and who secretes hepcidin? Which organ is responsible for secretion of hepcidin? Yes, hepcidin, as the name suggests, hep, that is liver. Very good. So I have a very intelligent audience today who was answering So many questions correctly. Very good. So, anemia of chronic disease, your hepcidin is elevated, and that is why iron is not absorbed from the duodenal cell. Can anybody now tell me which is the site of absorption of iron? Yes, duodenum, right. So, very good. Duodenum, the iron is not absorbed because of the increased level of hepcidin. So now iron is there as such, but it is not absorbed into the circulation. So where does this iron goes? It goes in, gets stored. It goes and gets stored in the duodenal mucosa as well as in the liver. Now, in what form in what form of iron it's stored in duodenal mucosa? Okay, can you tell me the storage forms of iron? Ferritin, yes. Ferritin. Another storage form, ferritin is stored in the mucosal duodenum. Yes, very good. Khushi, it is hemosiderin. Tanya, Khushi, Ninad, very good. It is mucosal is ferritin and hemosiderin. Yes, very good. So, uh, iron stored in mucosal enterocytes. Yes, uh, P part is enterocytes, ferritin, and liver. It gets stored in hemosiderin. So anemia of chronic disease, again, there is no deficiency of iron, but the iron is not absorbed. So the excess of iron is stored either as ferritin or hemosiderin. But since iron is not absorbed, we get anemia. Now, how will you differentiate all of these? I have purposely skipped thalassemia because it's a particular hemoglobinopathy. So it is always discussed in hemoglobinopathies. The rest, what will happen to serum ferritin in iron deficiency anemia? Serum ferritin iron deficiency anemia will be reduced. Sorry, it is serum iron. Very good, Ninad. Serum iron would be reduced. Serum ferritin would be reduced. Transferrin saturation. Transferrin was the transport form of iron. Since there's nothing to be transported, so your transferrin would also be reduced. Everything is reduced, everything is reduced. You're starving, you're fasting. So, what will happen to your hunger capacity? Your hunger capacity, TIBC, will be raised. Yes, very good. Your TIBC will be raised. And what will you find in marrow? Marrow iron would be absent. How did you detect iron in the marrow? What stain do you use? Yes, Ninad, no storage. There is no. Yes, very good. Pearl stain or Prussian blue stain. Anything do with the iron? It is your pearls or Prussian blue stain, right? So this is iron deficiency anemia. Your iron would be reduced. Everything would be reduced. Your TIBC will be raised. Now, what will happen in sideroblastic anemia? Sideroblastic anemia, I told you, iron there is no deficiency, so it will be increased because the hemoglobin is not being formed because of ALA synthesis defect. Otherwise, iron is normal. Even ferritin is also normal. Okay, ferritin is also normal. Your transferrin would be increased because there is a lot of, yeah, it could be normal or increased. So your transferrin, again, there's a lot of iron to be transported. So your transferrin saturation would also be increased. Now everything is increased. You are in a buffet. You won't feel like eating. You can eat it up to a limit now. So you don't feel like eating. What will happen to your hunger capacity? Your TIBC? It will be reduced. Very good. It will be reduced. Now what will happen to the marrow iron? Very characteristic feature of sideroblastic anemia on the marrow. What do you see? Anybody? What will you see on the marrow? Yes, you will see. Very good, Rakesh. You will see ringed sideroblast. Okay, ringed sideroblast. Now coming to anemia of chronic disease. Anemia of chronic disease, no iron deficiency, but iron is not absorbed. So your serum values of iron would be reduced. All the iron that is not absorbed in the blood, it is getting stored. So your transferrin would be, so your ferritin would be increased. What will happen to transferrin? Transferrin saturation. Transferrin saturation, because there is no iron that is absorbed in the circulation, there is no saturation also, low saturation. So this would be reduced. Since iron is reduced, your hunger capacity would also be reduced. Here, the marrow, yes, PIBC would be low, and your marrow iron would be normal. Okay, so this is your one slide, one table that is going to help you lifelong. That is going to be a very important one-stop solution for all your BD of all the microcytic hypochromic anemias. You should be very thorough with this table. It is going to be very helpful in all your practical exams, all your MCQs, and later in life to diagnose various anemias. Okay, serotonin, doctor, please means, okay, anemia of chronic disease. Anemia of chronic disease, iron is not absorbed. Why? Because of your hepcidin. Iron is not absorbed. So your serum iron that is in the circulation, it will be reduced. Iron is not absorbed, so it is getting stored. So your ferritin will be increased. Iron is not absorbed. There is no transferrin also. So your transferrin saturation would be reduced. As such, there is stored iron everywhere, but it is not absorbed into the circulation. Okay, I will come to the reticulocyte count also. We will discuss reticulocyte count when we will. If iron is not in the blood, how is PIBC decreased? PIBC is decreased because you have all the stored iron. It will be either normal or decreased. I must say normal or decreased, not totally decreased, but it will be normal to low. Okay, because iron is there. It's there in the body. It's not in the circulation, but there in the body, right? So I will discuss reticulocytes when we will discuss the hemolytic anemias. It's more important there. So marrow iron here is normal, right? Again, this is a very important table. You should be thorough with this table, right? You should know all the values. Now coming to the next question. How can investigations help in the understanding of the pathogenesis of the disease? So here we've seen CBC, MCV, and MCH. They were low, right? Hemoglobin also was low. Peripheral blood smear, we've already seen a microcytic hypochromic, and RDW was increased. So that means there is a increased production of the cell, but it is ineffective. There is variation in size and variation in size. That is RDW is increased. Iron studies we know, yeah, variation in size, RDW. Iron studies we know your iron is reduced, your ferritin is reduced, transferrin is reduced, and PIBC is increased. So it's a case of total iron deficiency anemia. Okay. If we are going to differentiate from other microcytic hypochromic anemia, we also have to do a CRP or ESR. CRP or ESR is going to help in differentiating which kind of anemia? CRP or ESR? No, yes, it's inflammation, and that is anemia of chronic disease. This would be raised. Hemoglobin electrophoresis, it is thalassemia. Bone marrow, yes, iron, presence of iron, deficient iron in iron deficiency anemia, ring sideroblastin, yes, ring sideroblastin, your sideroblastic anemia. And it is iron would be deficient in your iron deficiency. anemia. Right? Clear? Simple? Now, should I move on to the next case or any questions? Okay, thank you. We'll move on to the next case. So, case number two is a 39-year-old male, fatigue, breathlessness on exertion, difficulty in concentrating, and he also complains of a tingling sensation in his hand and feet for the last 3 months. Okay, he has some neurological fatigue, breathlessness. Okay, very good, Keshav. What is the very good? What is the most important history? See, history is very important. It's a macrocytic anemia, right? History is always important. You can get 50% of the diagnosis only in history. Somebody mentioned neurological features. Yes, neurological features are very characteristic in macrocytic or megaloblastic anemia, right? So, moving ahead, tingling sensation, yes, Shivraj. Neurological, no, this is okay. Somebody has mentioned pernicious anemia. This is right now we cannot say it is pernicious anemia. Pernicious anemia is definitely it is megaloblastic, but right now we cannot say it is due to pernicious anemia. For pernicious anemia, we have to do further investigations. Just now we know, yes, it is most probably vitamin B12 deficiency, but let's move on. Okay, fatigue, breathlessness on exertion, difficulty concentrating. Yes, myelination is hampered, so tingling is seen. Very good, Prayash. Myelination is hampered. Difference between pernicious and megaloblastic anemia. See, pernicious anemia, what is the cause of pernicious anemia? It is due to defect antibody to what? In lack of intrinsic factor. Very good. It is lack of intrinsic factor. Where is the intrinsic factor secreted from? Parietal cells of the stomach. Yes, very good, Ritesh. Samiksha, parietal, Khushi, very good. Parietal cells of the stomach. Malaria parasite possibility. I do not understand why malaria parasite possibility. No, malaria, no relation here. Okay, so intrinsic factor deficiency, presence of autoantibodies against intrinsic factor results in intrinsic factor deficiency, and intrinsic factor is an important plays a very important role in absorption of vitamin B12. Because it plays a role in absorption of vitamin B12, so intrinsic factor deficiency also results in vitamin B12 deficiency. That is your megaloblastic anemia. Right. So this patient, when you examine this patient, he had pallor, icterus, beefy red tongue. Very important. Beefy red tongue and decreased vibration sensation in the lower limb and mild splenomegaly. So there is a beefy red tongue, pallor hai, anemia hai, we know. Mild icterus, jaundice. I'll ask you, why is there jaundice in? Why is there jaundice in vitamin B12 deficiency? Come on, tell me. Mild icterus and mild splenomegaly. Yes, because of deformed cells. Because of deformed cells, they are getting destroyed in spleen. Because now, why are deformed cells formed? Hemolysis at spleen. Very good. Because of ineffective erythropoiesis. Yes, very good. Cells are large in size. Why are cells large in size? Can anybody tell me? Why are cells large in size? Of course, they are large in size, they are deformed, there is ineffective erythropoiesis, but why are they large in size? They are not able to mature. Basically, yes, because, yes, very good, Shivraj, Saloni, because of the DNA synthesis is defective. It is not defective, it is delayed. There is asynchrony between the nuclear and the site. Yes, very good. Asynchrony in nuclear and cytoplasmic maturation. That is why your cytoplasm will mature at the normal rate, but nucleus maturation will be delayed. Because of that, the cells would be large and it would be ineffective erythropoiesis. Because of those ineffective erythropoiesis, those RBCs will get destroyed in the spleen. Because of destruction in the spleen, you will get myodicterus and splenomegaly. Very good. I have a very intelligent audience, I must say. Okay, now investigations here again. Your hemoglobin is less, MCV 110, retic is zero point 0.8. Your iron panel, serum studies, iron panel is normal. Bilirubin is elevated. LDH again elevated. Folate is normal. Vitamin B12 is 98 picogram per deciliter. Okay, they have given you the peripheral smear also. Now let's see what all the questions they have asked. First, what is the most likely diagnosis based on the given history and lab finding? List the differential diagnosis in each case and provide the reasons. How can investigations? I'll tell you why is LDH elevated. Just give me a moment, I'll tell you why is LDH elevated. Okay, how can investigation? No, it is not a case of hemolytic anemia. Please note, it is not a case of hemolytic anemia. It's a case of megaloblastic anemia. LDH is elevated, but it is not hemolytic anemia. Okay, because of vitamin B12 deficiency, there is ineffective erythropoiesis, and because of ineffective erythropoiesis, the cells are being destroyed. The cells are being destroyed. Your remember your bilirubin metabolism. Okay, LDH is again raised here. So what is the normal value of vitamin B12? It's around 300. Less than 300, you say it is reduced. Okay. Yeah, 200 to 900 is the normal, but around 200 is on the lower level. Yes, it's around exact value is 200 to 900. But we take 300 as the normal. Less than 300, we take it at a lower level only. Right. So second question was list the differential diagnosis. Third is how can investigations help in understanding the pathogenesis of disease. Now, same way, whatever case is given, go step by step in the same manner. Check for the history. Very important feature in history. What is it? Very important feature in the history is your neurological deficit. Yeah, neurological problem. Physical examination, that is your beefy tongue and decreased vibration. That is what we studied now. And neurological findings in megaloblastic anemia, what do you term as? It is subacute combined degeneration of the spinal cord. Yes, subacute combined degeneration of the spinal cord. Okay, you can call it SACD also, right? Subacute combined degeneration of the spinal cord, right? Now, coming to the lab findings. Again, list down all the parameters that you have studied. What are the parameters that you have studied? It is your hemoglobin. What was your hemoglobin? 7.5. FBC, I don't understand the full form of FBC. Your MCV was 110 femtoliter. Retic 0.8. Vitamin B12 98 picogram per deciliter. Your bilirubin is raised and LDH is also raised. Now hemoglobin, we know it is reduced. MCV, it is increased. Retic is low. It's a little low. Why is it a little low? What's the normal reticulocyte count? Can anybody tell me what is the normal reticulocyte count? Yeah, 1 to 2%. In adults, it is 2% only. So it is low here. Why is it low here now? Okay, different books will give you different reticulocyte counts. Let's not go into it. Why is it low? Can anybody tell me why is your retic low here? Yes, because of ineffective erythropoiesis. What are exactly retics? What is reticulocyte? Decreased production, immature. It is immature RBCs or the newly released yes, RBC precursor. Newly released RBCs, immature RBCs. When there is excess of RBC production, the immature, newly just formed RBCs will also be released. They're not mature, completely mature. These are your reticulocyte count. The stain used for reticulocyte count, Fatafat, please tell me. The stain for reticulocyte count. Supravital stain. Which supravital stain do we use? Very good. Which supravital stain do we use? It's new methylene blue. Okay, brilliant crescile blue. Very good. So that is the stain. Vitamin B12 level here again is low. Your bilirubin and LDH are raised because of, yes, it's true. Jacqueline, it's true. So bilirubin and LDH are raised because of ineffective erythropoiesis. Uric acid can be increased. Why? Yes, Khushi, uric acid can be increased. In fact, at some of the books it is given uric acid is increased again because of ineffective erythropoiesis and increased destruction. But please note this increased destruction is not because of hemolysis. Okay, it is because of ineffective erythropoiesis, right? So all the lab findings we know. Now coming to the peripheral smear. Very characteristic peripheral smear. What do you see? First and foremost, you see what is this? Macrocyte. Yes, macroovalocytes. Very good, Samiksha. It is macroovalocytes. Macrocytes which are oval in shape, right? Because of, and how will you compare? Brilliant crescile blue. Yeah, you will compare a macrocyte with the size of a lymphocyte. Brilliant crescile blue. Okay, somebody asked with the for the reticulocyte stain, it is brilliant crescile blue. Yes, size of a small lymphocyte nucleus or could be a lymphocyte also. Okay, this is what, can anybody tell me? Basophilic stipplings. Very good. This is your basophilic stippling. And what are basophilic stipplings? What are they basically? They are your RNA remnants. Granules, yes, of course. What granules? Accumulated RNA and nuclear debris. Very good, Khushi. It is your RNA remnants. And they are multiple. Please note your basophilic stipplings are multiple RNA remnants. Where else do you see basophilic stipplings? Where else do you see basophilic stippling? Very common. Must be very good, Jacqueline. It is lead poisoning. Yes, lead poisoning, Ritesh. Lead poisoning. Okay, now, can anybody tell me what is this? Yes, very good, Keshav. It is a Howell Jolly body. And Howell Jolly body, no, Cabot ring, this is not a Cabot ring. This is a Howell Jolly body. I'll show you what is a Cabot ring. Howell Jolly body is what is its component? Your basophilic stipplings were RNA remnant. Howell Jolly body is a single body. Please note Howell Jolly single DNA remnant. Okay, basophilic stippling में RNA था. It is Howell Jolly is a single, basophilic are multiple, and Howell Jolly is a single DNA remnant. Basophilic were multiple bodies. Can anybody tell me other multiple bodies, multiple RBC inclusions? Just like Howell Jolly body single है, multiple bodies. It is your papenhema bodies. Where do you find papenhema bodies? Yes, very good, Samiksha. Where do you find papenhema bodies? Papenhema bodies are found in No, not in chronic condition. Very good, Jacqueline. It is found in sideroblastic anemia. Okay, found in sideroblastic anemia. Yes, Keshav. Papan bodies are multiple. Howell-Jolly body is single. Very important. As an MCQ, they can just give you the figure and ask you to identify the condition. You first have to identify whether it is single or multiple, right? So, next is your Cabot ring. What is Cabot ring made up of? Arginine-rich mitotic spindle, not microfilament. It is mitotic spindle. Okay, arginine-rich. And can anybody tell me the shape of a Cabot ring? Figure of eight. Yes, it need not be figure of eight. Commonly, it is seen as figure of eight only, but it can be a circular eight or zero. Very good, Samiksha. But it is a thread-like structure, so it can take any shape. Commonly, it takes figure of eight or zero, right? So this is a characteristic of your megaloblastic anemia. Okay, I forgot. Most important. What is it? It's your hypersegmented neutrophil. Can anybody tell me what is the criteria for calling it as a hypersegmented neutrophil? What do you have to check in a hypersegmented neutrophil? Yes, more than five lobes. More than five lobes. Okay, more than five lobes, but what? If you see more than 5% neutrophils with five lobes, or yes, very good, or even a single neutrophil with six or more than six lobes. So this is your hypersegmented neutrophil. Very good. Characteristic. More than 5% should be having five lobes, or even if you find single neutrophil with one neutrophil only with six or more than six lobes, it is enough to call it a megaloblastic anemia. Right? So, okay. Case we have already discussed. It's a case of megaloblastic anemia. Right? Megaloblastic anemia. My very good audience told me in the first slide only it is megaloblastic anemia. Now coming to the second question. List out the differential diagnosis in this case and provide reasons to rule out each. Can anybody tell me any mnemonic for all the macrocytic anemias that they have studied about? I will tell you mine, but anybody can tell me their mnemonic that they have studied? Causes of macrocytic anemias? Yeah, hepatosplenomegaly, I told you, no, just because the cells are getting destroyed. There's no hepato, but splenomegaly is there because the cells are being destroyed. Because of ineffective erythropoiesis, there is lysis occurring at the spleen, so that is why there is mild splenomegaly. Tics. Tics is what? Tics is the iron deficient, a chronic microcytic hypochromic, na? Tics is microcytic hypochromic. What is macrocytic anemia? I'll tell you, very simple. A, B, C, D, E, F. A, B, C, D, E, F are the causes of microcytic anemia. A say alcohol. Alcohol के साथ you can say liver disease. B is B12 deficiency. C is compensatory erythropoiesis. D is your drugs. E is endocrinopathy like hypothyroidism, and F is of course your folate deficiency. And how will you rule out alcohol and liver disease? This patient, what was the main thing? There is no history. Yes, there is no macroovalocytes. They have macrocytes. What do you mean by fat RN? Okay, B12 deficiency, macroovalocytes. And this patient, very characteristic, beefy red tongue, neurological deficiency, and vitamin B12 levels we know about. Tingling history, neurological defect, right? Compensatory erythropoiesis. See, compensatory, very good. Compensatory erythropoiesis will have low retic count. No, sorry, compensatory erythropoiesis will have normal retic count or maybe increased. And compensatory erythropoiesis, yes, compensatory erythropoiesis, your retic would be increased. Yeah, very good. There was a confusion at my end. Probably I did not say it correctly. Retic would be increased in compensatory erythropoiesis because the marrow is producing erythrocytes at a higher rate. So there would be increased retics. And plus there would be no neurological symptoms, right? Drugs. Again, drugs are very important. You have to take history. Very good. Very good. History. Endocrinopathy, thyroid disorders. Okay. FATRN. Very good. Okay, fine. This is also good. Fat RN. My mnemonic is ABCDEF. Whatever you're comfortable with, Fat RN or ABCDEF, right? Same disorder. Yes, drugs, but again, okay, VC deaf. Okay, your VC is deaf. Yes, endocrinopathy again, no history here. Folate ka again we will have levels. Yes, folate levels we will have to check. So this is the differential diagnosis. All these cytotoxic drugs are going to cause macrocytic anemia, right? Next question, we will come to how can investigations help understanding the pathogenesis of the disease? Again here, CBC, MCV was raised, your retic was, what was your retic? Retic was reduced, yes, retic was reduced. Peripheral smear, very characteristically, we saw a hyper-segmented neutrophil and macroovalocytes. Vitamin B12 was reduced, and if we could have done a folate would have come normal, right? So this is the investigations that we did here, serum bilirubin and LDH. Again, serum bilirubin LDH because of ineffective erythropoiesis. Additional investigations that we can do. Anti-intrinsic factor antibodies, again, they would be present in the case of your pernicious anemia. What will happen to your homocysteine and methylmalonic acid levels? Can anybody tell me what will happen to homocysteine? Homocysteine would be raised. And MMA or VMA, again, they would be increased. Why? See, I'll tell you. Go back to your biochemistry. Okay, go back to your biochemistry. Methyl vitamin B12 is necessary. Yes, very good. It acts as a cofactor. The methyl form of vitamin B12 acts as a cofactor for converting homocysteine to methionine. Once this is not there, homocysteine level will go up. And because of deficiency, your DNA production would be delayed or hampered. Okay, that is why you get nuclear and nuclear cytoplasmic asynchrony, right? Because of this step is not there, this is not formed, you get defective DNA maturation. And cytoplasm is going to mature at its own pace. Your DNA will be not there, so DNA maturation will be affected. That is why you are going to see macrocytes, nuclear cytoplasmic atypia. Also, this I told you. Now, adenosyl B12 acts as a cofactor for converting this propionyl CoA to methylmalonyl CoA. This step, methylmalonyl CoA to succinyl CoA, you need adenosyl B12. Once this is not there, this is going to be raised, this is going to be raised, and this will affect your myelination. That is why you will have subacute combined degeneration, right? Your increased Homocysteine level or high homocysteine is increased. Increased homocysteine is a risk factor for, yes, very good. Increased homocysteine is a risk factor for atherosclerosis. Okay, clear? Can I move on to the next case or any questions? Yeah. See, because in this step, methyl malonyl CoA is not there. Raised level of methyl malonyl CoA and its precursors. Increased raised level of methyl malonyl CoA and its precursors leads to increased synthesis of fatty acids, which are incorporated in your neuronal lipids. These fatty acids sometimes are incorporated in your neuronal lipids and your succinyl CoA cannot be formed. Succinyl CoA is a very important part of myelin. Succinyl CoA is a very important part of myelin. So your myelin formation is not occurring at a normal thing. So subacute combined degeneration can occur, right? This explains the all your neurological deficits. Homocysteine, increased homocysteine is a risk factor for atherosclerosis. Okay, can anybody, just now somebody asked about ferritin being a, ferritin is an acute phase reactant protein, so it is not necessary its level to decrease in iron deficiency anemia. When you don't have ferritin, where will you store, how will you get stored form of ferritin? When you don't have iron, how will you get stored form? So ferritin has to decrease. When iron, the normal iron is not there, how will you store it? Ferritin has to decrease in iron deficiency anemia, right? Okay, should I move on to the next question? Next case? Right. So we have a 25-year-old male with fatigue, yellowish discoloration of skin, dark colored urine. Is this for first year means? Okay, we have fatigue, yellowish discoloration of skin, dark colored urine for the past 2 weeks. Uh, Very good. Jaundice, dark color urine suggests hemolytic anemia. Very good. He has reported episodes of mild abdominal pain. There is no history of alcohol or blood transfusion or liver disease. Can anybody tell me why did we take a history of blood transfusion here? Why did we take a history of blood transfusion here? No, no, not because of hemosiderosis. Yeah, because of mismatch. Mismatch of blood, any blood acute hemolytic reaction can occur, mismatched hemolysis. Acute hemolytic reaction can occur and this can cause dark colored urine. Okay, right. So this patient has no history of alcohol, no recent blood transfusion, no liver disease. He has pallor, he has icterus, palpable splenomegaly, no lymph nodes, no neurological deficit. So my audience has already told me it's a case of hemolytic anemia. Which hemolytic anemia? That we will have to check. Okay, hemoglobin is 8.6, MCV is 105. Drug history, yes, we should have taken, ideally we should have taken drug history. No, it is not a case of PNH. We should have taken drug history because drug-induced hemolysis can be there. I guess this picture can also tell you what is the diagnosis. So hemoglobin 8.6, MCV 105, retic is 5. Patient can have cardiac murmur association because of anemia. Yes, because of anemia, this patient can have slow murmurs, but not as such because of hemolytic anemia. Yes, you can see spherocytes here. Very good. Just let's see the investigations. Hemoglobin reduced, MCV slightly raised, retic is very much increased. Your iron panel is normal, bilirubin again elevated, LDH elevated, direct Coombs test is negative. Please note direct Coombs test, very important finding. And this is the peripheral smear. You have already told me it's a spherocyte. Very good. Now, what is the most likely diagnosis based on the given history? Coombs test is negative, so it is not immune-related hemolysis. Very good, Seluni. Very good. It is not a immune-mediated. What is the most likely diagnosis? It is a hemolytic anemia, right? But which hemolytic anemia? Differential diagnosis and how can investigation help in understanding the pathogenesis? Let's try out answering each and every question. Now, history mein, what history have you seen? What history is most important here? History mein, you see dark colored urine. You see dark colored urine. Very important. It suggests hemolysis. Then you get fatigue and then you also see icterus. Physical examination, very important. You see pallor icterus. Sorry, icterus should come here. You see icterus and you see splenomegaly. Okay, important physical examination, yes. Lab findings, what lab findings? HB 8.6, reduced, that is anemia is there. MCV, normal or slight macrocytosis. Retic, it is 5%. It is elevated, right? So retic is elevated, right? And then bilirubin is again increased, LDH is increased, your direct Coombs test is negative. Can anybody indicate what is it? Considering the blood picture and the parameters that we know about? Yes, it is blood picture. G6PD deficiency, what do you say in the blood picture? It's a hemolytic anemia, normocytic, normochromic, just leave that. Which hemolytic anemia we are talking about? It is hereditary spherocytosis, right? Hereditary spherocytosis. Yes, you see bite cells in G6PD deficiency. Here you are seeing characteristic spherocytes. Okay, characteristic spherocyte. What is the parameter that should have been increased here? Which RBC indices is increased in hereditary spherocytosis? Very good. It is MCHC is characteristically increased. Why is it in, no, MCV is not increased. It is MCHC that is increased here. Why is MCHC increased? Okay, for that we would study about the pathogenesis. What is the problem in surface area is reduced? Yes, very good. Why is the surface area reduced? Because of the defect in ankyrin membrane protein. Yes, the defect here is in mutation in the ankyrin gene. And it is, what is the mode of inheritance? What is the mode of inheritance here? Very good. It is autosomal dominant. But it is autosomal dominant when there is mutation in ankyrin gene, which is the protein responsible for the shape of an RBC. Protein responsible for the shape of an RBC. Very important previous year question in your NEET PG. No, it is the spectrin. Remember, spectrin shape. Spectrin shape. Okay, this is responsible for the shape. Right. Primarily spectrin. But mutation in your ankyrin gene, mutation in your spectrin can also result in hereditary spherocytosis. But ankyrin ka it is autosomal dominant and it is autosomal recessive when there is a defect in spectrin. But autosomal dominant is more important than the autosomal recessive disorder. Clear? So autosomal dominant, there is defect in ankyrin, and autosomal recessive, there is defect in your spectrin protein. Now, because of this membrane defect, the cells achieve a spherical form. They reduce, basically, they lose part of their membrane and they become spherical, and the surface area is reduced. That is why they appear more concentrated and more rigid, right? More concentrated and more rigid. That is why when they pass through the vascular sinusoids of the spleen, they get trapped there and they get destroyed. That is the pathogenesis of your hemolysis, right? Okay. Now, if I give you a picture of spherocytes, please don't jump into the diagnosis of hereditary spherocytosis. Why? Because spherocytes are most commonly seen in autoimmune hemolytic anemia. Spherocytes' most common cause is autoimmune hemolytic anemia. Then comes your hereditary spherocytosis or G6PD deficiency. Also, spherocytes are seen in burns, hypersplenism, yes, ABO hemolytic disease of the newborn, and hemolytic transfusion. But the most common cause, when you see it, spherocytes, don't jump into the diagnosis of hereditary spherocytosis. It has to be autoimmune hemolytic anemia unless and until your DCT is negative. DCT is negative, then it is not autoimmune hemolytic anemia, right? Okay. Now, coming to the next question. So, this is a case of hereditary spherocytosis, right? Now, we have to rule out each and every the differential diagnosis in this case. And first of all, AIHA, that is autoimmune hemolytic anemia. I already told you DCT has to be positive in case of autoimmune hemolytic anemia. G6PD deficiency. Somebody just mentioned, you see Hind's body and you also see bite cells there. What is the other name for bite cells? Blister cells, or it is also called degmacytes. Okay, degmacytes are also known as bite cells. And plus you will have to do your G6PD levels. Pyroid kinase deficiency, again, you will have to measure the levels. Megaloblastic anemia, we've already told you, we'll have to check the vitamin B12 and folate levels, and you see macroovalocytes. SLE and arthritis viral infection can be a cause of autoimmune hemolytic anemia. Why will cause autoimmune hemolytic anemia? I'm not sure, but I can get back to you. It will not cause autoimmune hemolytic anemia. It can cause hemolytic anemia, but not auto. Okay, but I will definitely get back to you. Then next differential diagnosis, hemolytic uremic syndrome. What do you see in hemolytic uremic syndrome? Characteristic three features. Can anybody tell me? No, no. Microangiopathic hemolytic anemia is not here. Microangiopathic hemolytic anemia is, yeah, you see thrombosis. Very good, Khushi. You see thrombosis, you see renal failure, and you see, sorry, you see hemolysis. You see, I'm sorry, this pen is not working. Just give me a moment. Okay. Hemolytic uremic syndrome, you will see hemolysis, renal failure, and thrombocytopenia. Liver diseases, what do you have to do? You will have to check for the liver function test, right? All your liver function tests would be, yes, very good. All your liver function tests would be altered here. So this was the differential diagnosis for your hemolytic anemia. Now, how the investigations can help in understanding the pathogenesis of the disease. Peripheral blood smear, you've already seen. What did you see in peripheral blood smear? You saw spherocytes, right? Okay, and osmotic fragility test. What will happen to the osmotic fragility test here? Although this is osmotic fragility test would be, no, osmotic fragility test would be increased here because the cells are very, why is osmotic fragility test would be increased? Yeah, because the cells are fragile here. The cells are fragile here. Osmotic fragility test would be increased. Which disorder is osmotic fragility test reduced? Can anybody tell me? Sickle cell and thalassemia. Yes, thalassemia. Retics here is increased. Yes, osmotic fragility test would be reduced in thalassemia. Now your retics are increased. Why are retics increased? Can anybody tell me why is retic increased? Retics are increased because your bone marrow is trying to compensate for the cells that are destroyed in hemolysis. Very good, Rakesh. The retics is increased because your bone marrow is trying to compensate the cells that are destroyed in hemolysis. Again, serum bilirubin and LDH would be raised because of increased destruction of the cell. The most important finding is splenomegaly here. Splenomegaly, right? Because of cell destruction. Coombs test, we've already told you, Coombs test would be negative here and Coombs test would be positive in your autoimmune hemolytic anemia. Sometimes you also have to do genetic testing to check whether which gene mutation has occurred, right? So this brings us to the end of this session. Splenomegaly already we saw in another anemia. Yes, we did see in megaloblastic. Why? Because see, you will have to correlate with the retic count here. Because of hemolysis, it is specific here because the cells are being destroyed, they cannot pass through it. There it was because of ineffective erythropoiesis. Here erythropoiesis is occurring normally, but sorry, can you repeat your question, please? Okay, splenomegaly we already saw in megaloblastic anemia. There, the cells were destroyed because of ineffective erythropoiesis. Here, the cells are being destroyed because the cells are not able to pass through the vascular sinusoids. There, the cells are being destroyed, and all the RBCs are being destroyed that they pass through spleen. That is why you will get a massive splenomegaly here. There, megaloblastic anemia, splenomegaly would be mild. I hope it is clear. Okay. So moving on to the fine. This was the problem solving approach, right? Whenever you get a problem, just try to identify, brainstorm, list down all the parameters that you have been given. First and foremost, you will have to understand the history first. Look at for the specific pointers in the history. Brainstorm for all the parameters, right? Brainstorm for all the parameters that you get. Review all the options, whether it's an MCQ given to you, review all the questions that are given to you. I'm sure go step by step. You'll definitely approach at the correct answer. right? With this, I would like to, okay, tell us about LDH. LDH, I told you, no, that because of the increased cell destruction that is occurring, because of increased cell destruction, because the cells are being destroyed, that is why your LDH is raised. And hemolytic anemia, definitely LDH will be raised, right? I just now told you to remember your bilirubin metabolism. Your hemoglobin would be bilirubin metabolism. Your LDH would be raised.